Our first presentation will be about on-track, off-track glenoid. And Professor Giovanni, the stage is yours.
Thanks, my friends from Dubai. I'm so sorry that I have not the opportunity to stay to speak in your country that I always enjoy. My task today is to speak about traumatic anterior inferior instability. So only this kind of instability that usually is traumatic, and there is a dislocation of the humeral head in the anterior inferior position. We know that there are essential lesions. The most common lesion is the very well-known BANKART lesion, that is a detachment of the labrum between 3 and 6 o'clock in the left shoulder. This is the first lesion. The second lesion, most of the time very frequent, is the bone loss, the fracture, the compression fracture on the humeral head that is known as Hill-Sachs lesion. And I will try to explain during these 20 minutes that when we speak about Hill-Sachs lesion, we have to try to understand through images, CT or MRI, if is on track, and I will speak what is the glenoid track lesion, but very, very important is also to be able to look if the Hill-Sachs is off track. Usually the off track Hill-Sachs lesions are very large, are very middle, and are very close to the center of the humeral head, are very medial. And on the other side, so you have to keep in mind that besides the soft tissue lesions, the BANKART lesion, we have to study carefully the humeral head bone loss. But also on the glenoid, we can have bone loss, and we have different patterns, as I will show you in a few seconds, about glenoid bone loss. And we have to study the possibility of engagement between the Hill-Sachs and the glenoid bone loss. When we speak about the glenoid bone loss, we have to remember that there are different types of glenoid bone loss described by Hijito and Yamamoto. One is the fragment type. This is very interesting, and sometimes we have to look for this kind of glenoid bone loss that is called fragment type. Why it's important? Because very often, according to the Sugaya study, we can repair the bone to the glenoid. That makes sense, so we have an improved glenoid platform. Very interesting is that this kind of glenoid fracture that is not related to the dislocation, but is an avulsion fracture that this is very interesting, is a new concept, that keep the glenoid and the head very unstable from the bone point of view. Is called avulsion. It means that this shoulder became very weak from the stability point of view and very prone to have also dislocation with the subtle trauma. And sometimes it happens that your patient explained to you that they dislocated the shoulder not because a huge trauma, but because a small trauma. So you have to investigate if they have this kind of avulsion lesion. When we have a chronic dislocation, usually with huge number of dislocation, we can have an erosion type glenoid fracture. It means that once again is a compression fracture here on the glenoid, usually between 3 o'clock and 5 o'clock on the glenoid watch. Very interesting is also this paper. If you ask when the Hill-Sachs is created, the Hill-Sachs is created immediately after the dislocation, and BANKART has shown that the severity of the Hill-Sachs is related to the time the shoulder is dislocated. And Itoi did this study and then shown that the Hill-Sachs is created when the humeral is at 74 degrees of abduction, 27 degrees of external rotation, 3 degrees of external flexions. It means that the time the patient wait before reduce the humeral head is vital for the humeral head, is very, very important. There is a correlation between the time the humeral head is dislocated and the severity of the heel sacs. So most of the time they never have to wait too much time in the emergency. The question is when and which kind of surgery when we decide to treat this patient with the surgery. When we can discuss this after, and very interesting is which kind of the surgery. You know very well that around the world there are mostly two main techniques. One is the BANKART repair or BANKART repair with a plus, it means with the remplissage. On the other side there is the bone reconstruction is the Latarjet. I think, but this is my personal opinion, that there is no big difference between arthroscopic Latarjet or mini open Latarjet. So I will speak about Latarjet and BANKART repair. These are the two main surgeries around the world. And the main question is, because we want a tailored surgery on our patient, which are the parameters we have to study to understand if our patient need BANKART repair or Latarjet technique? I think that everyone knows very well the easy score. So when the patient is very young, less than 20 years, is a competitor, is playing, for example, rugby, there is some hyperlaxity, and there is some X-ray sign of bone loss on the humeral head, on the glenoid. According to Pascal Ballot, if the score of these risk factors is more than 3, you have a lot of possibility to have a recurrence if you treat this patient through an arthroscopic BANKART repair. If you follow this score, of course, many of patients that you will treat through a Latarjet because it's very easy to have more than 3 points. We try to improve, and this was published just the last month on arthroscopy. Me and Matt Provencer, we try to improve the study of the bone loss, not with the X-ray, but with the CT scan. And we introduce a new score that is the GTM score. You can find this paper on arthroscopy the month of January. And we use the same score, the same risk factor of Pascal Ballot, but we try to improve the study of the bone loss through the CT scan, introducing in this score the glenoid tract concept. In few words, Pascal Ballot is studying the glenoid bone loss through the X-ray and the heel sacs through the rotation of the humeral head. But you can miss something. And we think that if you are able to study with MRI or better to the CT scan, the glenoid bone loss and the heel sacs lesion, and as you will see in a few minutes, the relationship between the humeral head and the glenoid bone loss, you can be much more precise how much is weak your shoulder from the glenoid and humeral head bone loss. You know that in the literature there are many ways to study the glenoid bone loss: surface area method, superimposed, PICO method from Italy, and we did also this study because we think that the position of the heel sacs is very important. Now I will try to introduce you the bipolar study that I did with Steve Burkhardt and Izzy Toy. We think that when we speak about glenoid bone loss or heel sacs lesion, we have to study the interrelationship of these two bone lesions. So never study alone the glenoid defect. There is no sense to study only the glenoid defect or only the heel sacs. We have to look in a very dynamic interplay how these two lesions interfere each other. Steve Burkhardt introduced the concept of engaging. You can see in a non-engaging lesion on the left side, it means that in upper position, the heel sacs before the surgery, without repairing, before repairing the BANKART lesion does not engage. According to De Beer and Steve Burkhardt, if you have a patient like on the right side, where in upper position the heel sacs engage before the Bankart repair, this patient needs a lateral shear technique. But the big question is, what happened to the engaging if you fix the Bankart? According to Pascal Ballot and other researchers, and I agree completely, I think that any heel sacs lesion is engaging. It's up to you. It's up to you how many degree and how much force do you put when you test the engagement. So we think that it's very important to look at heel sacs if the heel sacs engage after the Bankart repair. So you have to fix the Bankart repair through the scope, and then you have to give a look to the heel sacs if the heel sacs is going to engage or not to engage with the glenoid. Which is the problem? The problem if you perform a Bankart repair, you don't have the courage that is normal to test the shoulder after the Bankart repair. So we tried to develop something different to see if the heel sacs is going to engage after the Bankart repair. And to do this, we use the concept from Eiji Itoi that he introduced the glenoid track. What is the glenoid track? This is our paper. The glenoid track is the blue zone that you can see here that guarantees the bone stability of the humeral head on the glenoid in upper position. So the glenoid track is the blue zone and is medial to the footprint. According to the Eiji Itoi study, the glenoid track, this is the shoulder in upper position. This is the tuberosity. Here is the cuff. Here is medial to the cuff. GW is the width of the glenoid. And according to Eiji Itoi's study, the glenoid track is around 83% of the glenoid width. So I measure GW, I look at 83%, I stay medial to the footprint, and GT is the glenoid track. This zone, the blue zone, is very, very important in upper position because guarantee the stability of the humeral head on the glenoid. So the glenoid tract, I call it the golden part of the humeral head in stability. If you pay attention to this video that I did with my engineer, because it's a very dynamic concept. This is the ligament, you have the Bankart lesion, and in 80% of the case, especially in recurrence, you have the heel sacs. You have to study the relationship between the heel sacs and the glenoid tract. You can see here that the heel sacs is completely within the glenoid tract. So if you fix the ligament, you have still some glenoid tract that in upper position guarantee the bone stability. So you have bone stability and ligament stability. You have a good shoulder after the surgery, and we feel comfortable to treat this patient with arthroscopic Bankart repair because it's on track lesion. The heel sacs is within the glenoid tract. Look, and you will understand that the key point is the position of the heel sacs. Once again, we have a dislocation, Bankart lesion, but we want to give a look to the heel sacs. Look, this time the heel sacs is very large. There is a very large medial extension of the heel sacs. It means that if I fix this shoulder with 2 anchors, after 6 months, my rugby player go back to play, but there is no bone that guarantees the stability, and I have an overload of the ligament. That's the reason that if I treat this pattern of patient with off-track heel sacs lesion, I have a huge number, 80%, 70% of failure. Why I think this is a good concept? Because as I told you, you have to consider also the glenoid bone loss. And the more glenoid bone loss you have, the more possibility you have that the heel sacs is out of the track, is off track. And you can measure this because if you know that the glenoid tract is 83% of the glenoid width. We know that this is the normal glenoid tract. But because here there is a glenoid bone loss, of course, the width of the glenoid is smaller. And the smaller is the glenoid, the smaller is the glenoid tract. The smaller is the glenoid tract, the more possibility you have that the heel sac is off track. So it is unstable from the bone point of view. That is interesting. So we have to consider patients that have glenoid bone loss and also the position of the heel sacs. According to this, we did a classification. We have patients that are on track, that are off track, and patients that have different glenoid defect. The critical glenoid defect, according to the literature, is 25%. So the most frequent patient you will face are patients that are on track and they have less than 25% of glenoid bone loss. And if you give a look to the literature, the main advice is in these patients that have no dangerous heel sac lesion, the heel sac is small, is very lateral, is on track lesion, and you have a glenoid bone loss that is less than 25, in this patient, you are advised to do a BANKART repair. But I did a magnification of this group of patients that is huge. So we have a patient that is on track. But when we say that the glenoid bone loss is less than 25%, in my mind, there is a huge difference between 0 and 25. So if you read the paper from Japan or from North America, from John Tokish, they did a very interesting study. They introduced the concept of subcritical glenoid bone loss. It means that if you have a patient that has a small heel sacs and minimal, very minimal, few millimeters, maybe 2-3 millimeters of glenoid bone loss, you are comfortable to make a BANKART repair. But pay attention, because if you have a patient that is on track, but the glenoid bone loss is between 13% and 25%, you can have a low rate of dislocation, but if you evaluate your patient according to the SANE or the WOSI score, the results are not good from the functional point of view, probably because you fix the capsula, the ligament on the glenoid bone loss, and you can have a reduction in upper position of the ROM, of the range of motion. So I think that also the concept of subcritical bone loss that is between 0 and 13 and 13 and 25 is very, very important. So feel comfortable to fix your patient with BANKART repair if they are on track, if they have a glenoid bone loss that is less than 13%, the concept of subcritical bone loss. So always give a look to the position of the heel sacs, because the more medial is the heel sacs, the more possibility you have that the heel sacs is outside. You can study the heel sacs through the CT, but also through the MRI. You can have also fragment type, and we feel that if the fragment is enough stable, the quality of the bone is good, you can repair, and you have a bony BANKART lesion, and you can try to fix the bony to the glenoid, and Sugaya has demonstrated that you have a very good integration, and you can restore the morphology of the glenoid that is a pair. You restore the diameter of the glenoid width. The other group of patients are patients that have a very lateral, not dangerous heel sacs, but they have a very important glenoid bone loss, most of the times in recurrence, anterior-inferior dislocation. In these patients, the choice is very easy. You have to reconstruct the platform of the glenoid to the coracoid transfer. So the lateral G in our hand is the main indication. Then there is another group of those patients that are off track, and they have a glenoid bone loss that is less 25. I did once again a magnification of these patients. And you can have a patient that has an Hill-Sachs lesion that is off, mostly for two reasons. The main reason, one of the two main reasons is case one, where the Hill-Sachs is very large. The Hill-Sachs is very medial. That's the reason the Hill-Sachs is off. So the culprit is the Hill-Sachs. Then we have patients that are in the middle, and the third group are those patients where the Hill-Sachs is off, not because it's medial, not because it's large, but because there is a huge glenoid bone loss. So in these patients, the culprit is the glenoid. So in group one, where the culprit is, the position is the Hill-Sachs, we feel that to do a BANKART repair and remplissage is the key point, because the culprit is the position of the Hill-Sachs that is very large, but usually is very medial. Then we have case two, where the culprit is half and half, the position and the glenoid bone loss. And we can discuss in this patient if perform a BANKART repair and plus, or Latarjet technique. In group three, where the culprit is the glenoid, for us there is no choice. Of course, the Latarjet, arthroscopic or open, is the elective treatment. And the last group are those patients that is a tragedy. They have an off-track lesion, but it's very, very rare. They have an off-track lesion. The glenoid bone loss is very huge. So in our end, most of the time, the Latarjet works very well also in these patients. But of course, if you have an Hill-Sachs lesion that remain off-track, besides the Latarjet, of course, you can use a remplissage, or you can use an allograft like the Hillac crest allograft. Thank you very much for your attention. I don't know if you have some questions now, or if you want that I switch to the other talk.
I think we can proceed with the next talk, which is anterior shoulder stability or stabilization. And we will have a few minutes after that for question before we, while Dr. Ali will prepare his presentation. So Giovanni, you can go ahead with your second presentation.
So I'll be very fast. BANKART repair. So this is a classical lesion, and the main goal is to repair with a shift from south to north of the capsulolabral lesion. That's the reason that we most of the time use 3 anchors, one at level 5, one anchors at level 3, and the other anchors at level 1, and we put the stitch inferior to the anchor just to give a shift. Okay, this is the meaning of the BANKART repair. You have to shift from south to north the BANKART lesion that I described to you just a few minutes ago. When you use anchors, when you use stitch, you can see this is a ligament lesion. You have a dislocation, but if you are able to put the anchors, the stitch in the right way, and you have a good patient selection according to the different score, you can stabilize the shoulder from the soft tissue point of view, performing a good technique. You can use your camera from posterior, from anterior superior, but very, very important is to put the anchors in the right spot. This is a right shoulder. We are watching from anterior superior. Just a very fast example. We retrieve one of the stitch from posterior, and very, very important, we use the suture passer inferior to the anchor, because when we tie the knot, we want to shift the capsule that is the main concept from south to north. And recently there are many surgeons around the world that are putting an anchor at 6 o'clock from the posterior superior portal. This is a classical knot that I'm sure you know very well. You can use a Revo knot, you can use a sliding knot. There is there is no one that is better the other one. You have to perform the technique in the right way. You can see that in this kind of patient, we are using the anterosuperior portal to view, and we are tying the knot. You can see that we are shifting from south to north. We are putting the ligament once again under tension, and we are trying to reconstruct the bump. That is very important to improve the depth of the glenoid. This is a case, I don't know if you can hear, is a male. He dislocated, is 17 years old. He dislocated the right shoulder, is right-handed. The mechanism is very important. If you want, we can spend time about this. The surgeon is investigating the mechanism of the lesion. Three more. So we have 17 years old, four subtle dislocation. Sub-dislocation, not dislocation. And if you give a look to the image, you can see that there is a good sclerotic line, and on the MRI, you can see without any special measurement that there is a very small heel sacs and there is a BANKART lesion. In these patients, you can use different technique, but always we taste the patient before the surgery, just to have a confirm of the direction, that is the key point, the direction of the dislocation, and also to taste the laxity that sometimes accompany the dislocation. So it's very important to give a look also if there is some kind of laxity, of patholaxity posteriorly, inferiorly. So this time you are watching the right shoulder from the back. You can use the camera, as I told you, from the back or from anterosuperior. It's up to you. Many surgeons, because they have a better view of the glenoid, they prefer anterosuperior. We feel comfortable with them both. So you can see the BANKART lesion that usually is between 3 o'clock and 6 o'clock. You have to taste also the quality of the ligament. You have to make a debride. And while you are detaching, doing the debride on the glenoid neck, you have to look for subscapularis to improve the shift. Then, very important, there is another interesting point. Where is the portal you have to put the stitch? From anterior, like in this case, or there are other surgeons like Christian Gerber, they prefer to use the stitch, to the suture passer from posterior to have better shift. Once again, you have to put the anchors at 5 o'clock, very close to 6 o'clock. You can use different type of anchors. We use anchors that are not in titanium, that are not bioresorbable, and that are double loaded with the fiber wire. This is the point. You are in the right shoulder, you can decide, and we can discuss this, to use the suture passer from posterior, and you can see that you will have a different orientation of the stitch. We are very close to 6 o'clock. And you can see here is the anchor, and we have to pass the stitch very distal to the anchor because we want the shift, that is the key point of this. Or you can also choose to introduce the suture passer from the anterior-inferior portal that we do usually, and sometimes you need a good help because I want a huge bike. I want so much tissue, especially if the tissue is not of good or excellent quality, and sometimes you can have some difficulty to use the spectrum to pass with the spectrum to the soft tissue. We use the PDS as a shutter relay. And once again, there are different philosophy. You can use 2 anchors double loaded. You can use 4 anchors single loaded. You can use also different kind of stitch, simple stitch, matrix stitch, Cassiopeia conformity. There are different philosophy. and you have to pay attention when you retrieve the wires through the cannula. But I think that the patient selection, the good quality of the tissue you are going to fix, and an excellent technique most of the time, if the patient selection is fine, you can have excellent results. Sometimes during the surgery, when I do this passage that you can see, this step, and I have the sensation that for some reason, for genetic issue, or because it's a recurrent dislocation, the quality of the soft tissue is not so good, I shift to the Latarjet. In this patient, you can see the heel sac is very small, is very lateral, so we didn't perform any kind of remplissage. Just some trick. Very important is the inclination of the cannula. If you don't use the inclination in the right way, or you don't put the anchor in the right way with the right inclination, maybe two parallel, you can have something like this. And especially any kind of anchors, but especially if, as many years ago we did, you use anchors that in titanium, and you don't realize your mistake during the surgery, this is a nightmare for the shoulder. You have an arthritis in a very, very young patient. So always pay attention to the position. You need to be very accurate when you put your cannula and when you are putting your anchors. You have to respect the inclination. You can see here some video. This is not perfect inclination. I did this talk at GMH meeting many years ago, speaking about the pitfalls that you can have during this surgery. You can see here, because sometimes it's very useful to put an anchor also posterior to recreate the hammock. If you miss the right inclination of the cannula, it's a complication along all the surgery. So the position of the cannula is one of the key points, as you can see here. You need a very good inclination of your cannula, even if you work from anterior or you work from posterior. Once again, you have to study very well, not only from the clinical point of view, but also from the image, X-ray, MRI, CT scan, especially in those patients that have a bone fracture or they have a glenoid bone loss. You have to pay attention not to introduce the anchors into the fracture. Otherwise, you can have an extrusion of the anchors, like in this case, and you can have a picture like this. So you need to reoperate your patients. And so keep in mind that the key point of this surgery is to recreate a shift from south to north of the anterior, and is very frequent in our end also of the posterior band. So you have to put the anchor proximal and to take the tissue distally. So when you tie the knot, you have a shift from south to north, anterior and posterior, to reconstruct the hammock. If you have the sensation during the surgery that the quality of the tissue is not good, is not a shame, you have to shift it to a better surgery that guarantee much more stability. In those cases, we prefer the Latarjet. If you have, during the BANKART repair, the sensation, because you studied the position of the heel sacs, that the heel sacs is large, is very medial, feel comfortable to reinforce the BANKART repair with a remplissage. Thank you very much.
Thank you. Dr. Ali, you can proceed, please.
Good evening, everybody, and thank you, Giovanni, for excellent visual presentation. As usual, I'm always impressed by the illustrative and visual presentation that you do in courses. So it was another wonderful presentation from you today. Thank you. So I'm going to talk about the posterior shoulder instability, and I thought this is a perspective of a surgeon that has worked over the past 15 years in this region to see our own population. Now, we are not dealing with a rugby player, we're not dealing with a baseball player or American football player. We are dealing with our own people here and what I am seeing, and that's what I am presenting in my own population. So we know globally posterior shoulder instability is not common, is quoted around 10% of all shoulder instability. And mainly it happens in active, young, and competitive athletes. In our region, the more I see are the competitive athletes, and more from a repetitive micro trauma from specific activities, push-up, weightlifting, rather than a single injury. It happens, there is a single injury sometimes I'm seeing, but most of the time, someone who's going to the gym, doing weight for many months and years, and then over time, this is what laxity with their small tears that develop in more symptomatic instability posterior. Another what I've noticed is most of the people that present is more of a teenager sometimes, and I have a population of teenagers, and most likely probably for the pre-existing capsular laxity, and mainly in our region, our indigenously population, and maybe in the Asian, I see a lot of capsular laxity in those patients, and sometimes with the trivial injury like a fall, like a simple fall, and they then are presenting with this pain and sometimes subluxation. I'm also seeing patients from the military and people who are now having something like a jiu-jitsu training, and this is something that's been introduced over the last few years, and I'm seeing people from the military with injury related to shoulder from those type of exercises. Now, as we know, shoulder instability differs from anterior stability. So accurate identification and prompt treatment is more difficult than anterior. Sometimes it's missed because it's a pain and it's a vague pain, and this is what we're talking about, the symptom presentation, and it's not easy to sometimes diagnose it. Now, just to go quickly over the anatomy and pathoanatomy, as we all know, on the posterior aspect of the shoulder, what's hold the stability? What gives the stability from translation posteriorly is the posterior band of the inferior glenohumeral ligament, which is not as strong or robust as the anterior band of the inferior glenohumeral ligament. Now, also the posterior capsule is not as robust as the anterior capsule and the anterior band. So I see the tissue posteriorly weaker than the anterior structure. What I've seen as well, that the posterior labrum is not as thick and is not as well developed often as the posterior as the anterior labrum. So some of the things that's quoted, excessive glenoid retroversion, glenoid hypoplasia, I have not seen that commonly in my population, but the importance of the chondrolabral containment, that's one of the things that when that's lost, often patient will present to you. A dynamic stabilizer for posterior stability, subscapularis, also the subscapulothoracic muscle, they are all contribute to the posterior stability. So overall, the important structure that we have to concern ourselves with when it comes to posterior stability are the posterior band of the inferior glenohumeral ligament, the posterior labrum, and the posterior capsule. So when it happens, a loss of chondrolabral containment, whether it's a small tear in the labrum or a chondral lesion, may present itself with posterior instability. I have not, in my population, been presented or rarely been presented with significant glenoid bone loss. So when we talk about classification, and this is mentioned in the text, in the books, and either you go dimensionally, whether unidirectional, bidirectionally, and I'm not going to talk in this talk, I'm not going to discuss in this talk about MDI or multidirectional instability. Or another classification is a traumatic versus atraumatic subluxation. What I've seen in our region mainly is a unidirectional and sometimes bidirectional. What I say bidirectional is postero-inferior instability, and they are much common in my practice than a multidirectional instability. But with those, even with those unidirectional, bidirectional, often I see a pre-existing capsular laxity. Now, people mention in the literature about the habitually subluxation shoulder. To be honest, I don't see those rarely see those in my practice. So with regard to clinical assessment, what are the symptoms? Sometimes symptoms are not like the anterior instability. Often they come with a pain or painful popping. That's what they say. The shoulder pops as I move my arm from back to front, and often with the arm in about 90% forward flexion, adduction, internal rotation. Those are the common presentation. Now, it's not commonly to have a posterior or recurrent posterior dislocation. There could be one episode, a traumatic, significant trauma, but often more of a subluxation. Now, those are the tests that's often used to assess the shoulder, particularly when you are suspecting posterior instability. Posterior drawer test is something like the opposite of anterior drawer test. Jerk test and Kim test for posterior inferior instability. The sulcus sign basically to look for global hyperlaxity of the shoulder, and often part of the MDI. So the above one is the above description is of a jerk test, and basically when you start with the arm more of adducted, forward elevated in an internal rotation. As you bring it from an adducted position to abduction, you hear a click, and that could be a painful, whereby also not forgetting, you have to, when you do this test, you have to apply a posterior force, and that posterior force will push the head backwards. And then as you bring it to a more abducted position, that head will clunk, or that will pop back into the glenoid, causing a painful click. This is the first jerk test. The other one is the Kim test described by Dr. Kim from Korea. And this is more of applying an axial force into the glenoid with the arm in a little bit of adduction and internal rotation. And then in the same time with the other arm applying an inferior force and going back and forth between adduction and abduction, and then you will feel pain, and the patient will feel pain as you are applying this inferior force. And this is more for posterior-inferior labrum tears. And with regard to the assessment, imaging used for assessment, I found useful to use MRI. MRA as well, which is arthrogram, MRI arthrogram, is very useful in younger population. But I found myself more depending on the MRI. Now, CT scan for posterior instability or posterior pain and instability is not commonly, I don't commonly use this except for failed cases. For someone, a case that has failed, done somewhere, failed, or some of my cases that failed, or somewhere where I am worried about multiple dislocation, or in a patient who had seizures. So the management starts always with conservative, and particularly with posterior instability, sometimes I use a steroid injection when there is an overlap between, is it a slab, is it bicep tendinitis, is it truly posterior? So sometimes I use under ultrasound guided injection of a steroid into the bicep sheath. Or sometimes a subacromial injection if I feel there is an overlap and I needed to negate those confounding type of presentation. And that's helpful sometimes in my own office when I do these things. I found the primary treatment non-operatively initially with cuff and periscapular muscle strengthening, trying to rehabilitate the periscapular muscle and improve the scapulothoracic rhythm. I think those are, particularly in atraumatic posterior instability, I think those are very helpful, and you have to, those patients have to undergo this for at least 2 to 3 months and do at least 20 to 30 sessions with a good therapist. Now, it's found in some studies that this type of treatment is not helpful, particularly when there is definitely a traumatic event and there's evidence on the MRI of a definite posterior labral tear. The cases that has failed therapy, then we will consider them for surgery. I have been doing arthroscopic posterior labral repair for a long time, and I have not done open posterior capsular shift. I can remember I tried to do all the posterior capsular plication, doing it through arthroscopic means. Now, recently more people are talking about open bone block and revision cases with significant bone loss, and the use of sometimes even a reverse rhombolysis type of procedure as an adjuvant procedure in someone maybe with some bone loss and large reverse head sac. I would leave the modified McLaughlin's. Basically, those are for large reverse head sac. I'm not going to talk about it. Those are in some rare cases with seizures. This is the position. I do a lateral position, lateral decubitus position, and this is the setup that I do. Those are the portals that often I use in most of my surgery. And if you see the PL there, the posterolateral portal, which is mostly the one I use for putting my anchors into the posterior and posterior inferior labrum. This is mainly not this. You have to check this through a needle from outside in to choose the right place for it, but it's around that region there. So to start, I have a few cases just to present, and the first case is 17 years old man and a 17-year-old boy, and young man I should say. He presented to me with popping sensation, and you can look at his scapula. You can watch his scapula or scapular rhythm, and you can see the popping and the abnormality of that. You can see it through the scapulothoracic, and you can see the popping as he brings his arm down, and it looks like the head clicked back into the joint. So this guy had an MRI, and you can see the MRI. You can see this posterior labral tear and small paralabral cyst here. You can argue there is a blunting of the posterior glenoid, but I don't see a definite large bone loss there, but there is some blunting there. And you can see it on the sagittal T2 sagittal view, and with that. So following failure of his conservative management, I did send him for, I sent him for physiotherapy, but seemed to be, it did not work. So this is, I'm viewing from anterosuperior, and this is the canal coming after from top, and I would say from a superior portal, posterior superior portal. As I showed you through the posterolateral portal that I use to use my anchors, and I use my work. Now, I still use the standard posterior, and you will see that this is just to put in the anchor, and I use the interval portal as a working portals to take the suture anteriorly. But look, I will come now from not from the top cannula. I'll be coming from the standard posterior portal that I used to get my camera in first time. And this is where I can get my tissue penetrator in. And then this is the old suture, by the way, anchor. This is not a big anchor. This is an old suture anchor, 1.4. And this is the way, and I put in a knot there, a sliding locking knot. And in this particular guy, I've used two anchors, and I felt that was enough. And you can see, and he had a small tear anteriorly, and that was repaired, a partial tear anterior, that was repaired with one anchor. another case is, this is an interesting guy who came in with catching a lock, and he's 30 years old, and he had a painful limitation of range of motion, positive chems, but interesting, he had something like a buckle tear, like a bucket handle tear of the posterior labrum. And you can see that, and that was, seemed to be, you cannot repair that, you cannot push it back to the posterior labrum to fix it like a meniscus. I think this is something, it has to go, and basically decided to go to remove this. And I, in the same patient, after removing that, this is what I've done. From a transcuff portal, through a transcuff portal, there was a slap lesion with this. I fixed a slap lesion. You will see I use a small cannula for the transcuff portal previously, and now I'm trying not to use a cannula. This is a shuttle spectrum that comes out from the anterior cannula, the interval cannula, and this is just to pass in, shuttle the sutures. And after I fix the slap lesion, this will, sorry for the slowness of that. I hope the video is clear to you. I finished first after putting 2 anchors in here. This is the second anchor, and you have to see where I'm coming from. This is the only way to get a good angle on those superior labrum, sometimes through a transcuff or posterior one. But this is, again, I like to do a lot of my own knotting. I like to tension. I use as well a knotless anchor, and you will see that I will use a knotless anchor. But in this case, I did 2 anchors here for the more superior, posterior superior, and this is an anterior to a small tear anteriorly. Now I go back posteriorly. This is where I remove that flap lesion or that buckle handle. And you can see it again from anterosuperior transcuff view. From transcuff view, you can see that. And this is the debridement of the posterior labrum, posterior glenoid. And look at the view that you get from coming from down the arm. And then you put, you change a view, you drill from the transcuff, and then you put your posterior anchors. And I felt those 2 anchors, in addition to the top anchors, that was significant. This guy was done about 2 years ago, and he's doing very well, up to date. Another case is interesting case is a guy who fell off a bike. He's 32, he's a policeman, chronic pain and catching, did a conservative treatment. He has a limited range of motion due to pain and apprehension, particularly in some induction internal and some locking and catching as well. He had a positive chem and positive axial low and shift. And the MRI showed a posterior labral tear. Sorry for not showing some images, but often the images showing small tears and sometimes not showing very clearly. But when you go in and look at this large chondral fragment that's sitting in front of you as you go inside, look at the amount of the synovitis. Now, I did not realize recently that he has a subluxation or he has some sort, but the shoulder, I felt it a little bit tight. He has significant synovitis, and this is from posterior. Now, this fragment sitting in the axillary fold posteriorly. So you need to get in, you need to get yourself into anteriorly, and sometimes in a tight little bit. His cuff and his biceps seem to be fine. The interval seemed to be thickened and inflamed, and look at that reverse health sac. Now there is a reverse health sac in this particular guy. It's not deep, but you can. This is where it is. It came from the initial probably dislocation when he had that fall. Now viewing from posterior and this trocar coming from anterior, and I'm just looking for the extent of the tear. Now changing the camera goes from anterosuperior. Then you have this larger fragment. I'm gonna put a cannula posteriorly, and then through this cannula, you remove those fragments. So now look at the chondral lesion that has happened. Look at the loss of the articular cartilage posteriorly. Now the bone is still there. There is no significant loss of bone, but loss of cartilage. And those are the pieces of cartilage that are flying around, whether it came from the reversal sac or coming from here. Now look at that piece that came out, that's been flying all around the place there for him, causing him a lot of significance. So I went ahead and from the superior portal, as I talked to you about, as I do most of the preparation of the posterior glenoid, and I make sure that that the labrum is well liberated before I go ahead and do a shuttling. And in this particular case, interestingly, I decided to a knotless technique. So this is the knotless technique, and I did 4 anchors here. And I tried to put in the anchor a little bit on the bone, a little bit anteriorly to cover it with the posterior labrum and capsule. As you see, I take part of the capsule along with the labrum. It's almost a capsular plication as well. It's not just, although his labrum, I wasn't happy about his labrum. I felt it a little bit, it's not so good quality, so I incorporated more of the capsule as well. So this is it. This is what it looks after the repair. I've used 4 anchors in this particular case, and this is what it looks finally. So, and the last case I'm going to show you is an 18 years old, and this is a case interesting. I'll tell you why it's interesting, because I'll let you know at the end of the video. But he again failed. He's such a young boy. He was 17 when we started, and then he had the positive jerk and chem test. To the MRI, suspected small posterior labral tear, and this is what appears from. This is posterior viewing, and look at the capsule. I mean, the laxity in that capsule, as you see it, he has a capsule laxity. And again I shift and I go from anterosuperior and I come on top of, I use that. Now, some people say they can do it through anterior portal. They approach the preparation of the posterior labrum from an interval type of portal. I found what I do is more suitable for me and my own, and this is the way I do it. So in this particular case, I put in a couple more, 3 anchors, I believe. So this 1 anchor, and those are all suture anchors. But again, I wanted to do more of capsular plication. I wanted the tension and the posterior band of the inferior glenohumeral ligament, and doing that, you need to take a little bit of the capsule. Look at, I wanted to take some of that capsular redundancy inferiorly. So we will see how it looks eventually. Again, I do a knotting technique in this particular, for those 2 suture. I use a tissue penetrator. I use sometimes a shuttle, sometimes a tissue penetrator. I switch from one thing as I wish, but in this particular case, look, I've now tensioned it, and you see the way it's tensioned. Now I use 1 big anchor here to as a knotless to even reinforce the repair, and this is the way it reinforced. And as you see, a strong bumper type of in the posterior inferior. And the reason why I'm showing this, 8 months after this repair, the patient had recurrent symptoms. So it's something for me to think about and wonder about on what went wrong. Maybe something that I missed. The bone loss and posterior shoulder instability, I mean, it's not as common as the anterior, and is not commonly talked about, but It's what has been used in the past to address this iliac crest bone block, or a distal tibial allograft, which was found to be the most suitable. But many countries don't have access to allograft, so we do still use iliac crest bone graft. Again, not many studies, but some people do it through an open technique, and some people do it through a mini open arthroscopic assisted technique. As you see, this is an open technique by Antosh there, and using distal clavicle in a good fashion. Rehabilitation is this is the way I use it. I put the patient in abduction in neutral, and I'll keep it there for about neutral to 30 degree, neutral to 15 degree of external rotation. I'll keep them for about 4 weeks. After that, we start range of motion exercises, and I don't start strengthening until about 8 weeks. So in conclusion, the posterior labral injuries are infrequent, the Gulf region as compared to the anterior instability. And I see it mainly in young people or gym goers. Hyperlaxity in our region it's common. I've seen internal impingement with the small tears of the articular sided calf tears because of this micro instability. And I feel that posterior shoulder instability may be a confusing presentation to most orthopedic surgeons. It's a challenge. So you need to think about almost twice about it as you would think of an anterior instability. Now, often negative MRI in our region, it does not mean anything. If you have very strong suspicion of posterior instability, you may have to go and do arthroscopy to give you the final verdict and repair at the same time. As I said, I do arthroscopic posterior labrum repair and capsular application if I found there's a significant capsule laxity. And in failed arthroscopic repair, I would recommend either an open technique or a bone block technique. Thank you.
Now I think we've just finished with our last presentation, which is about letter J. Giovanni will give around 10 minutes to talk about it, and then we will open the stage for all the questions.
This is the letter J technique that you know that is the osteotomy of the coracoid. Very important is to be very precise when we perform this kind of osteotomy. But personally, I think that the key point of this kind of surgery is to perform a split of the subscap. In few words, it means that when we have to place the coracoid in the right place, when the glenoid bone loss is, you need to perform this kind of access to the glenoid, not through a tenotomy, but through a split. So you do not disturb and you do not create a iatrogenic damage of the tendon. This is a picture that describes the three effects of the letter J. The number one is the graft that guarantees the bone platform. Number two and number three are very important, is the sling effect that is from the common tendon and from the most inferior part of the subscap. When you perform the letter J technique, always give a look to the bone, not only to the heel sacs, not only to the glenoid, but always look at the coracoid. You need to have a safe, a very good, in good shape coracoid. Sometimes you have a sequel of a fracture of the coracoid, or you can have a fracture, and you have not to miss this during the imaging study. Otherwise, you can get some problems. This is the right shoulder. I did a bigger access just from a didactic point of view. Of course, it's the classic anterior approach between the pectoralis major and then the deltoid. I call this the retractor surgery. I keep in mind this right shoulder. You can see this is the coracoid. This is the pectoralis minor. This is the key point retractor for the coracoid osteotomy. I'm doing a release on the most lateral part of the coracoid. I release the coracohumeral coracoacromial ligament, and I protect with this the subscap. Then I go on the most medial part of the coracoid, and I do a tenotomy of the pectoralis minor tendon. That is, in this picture, is very clear. I want to have a good view of the coracoid. You can see here the tendon, the pectoralis minor tendon. I want a good view of the coracoid, then I perform from superior to inferior at level of the knee of the coracoid, a coracoid osteotomy that mostly is around 20-22 millimeters. It is very important to have a good piece of the coracoid. This is a very nice image of the anatomy of this superior district of the shoulder. The other step that is very important is that you need an irritation at the bride of the most inferior part of the coracoid. I don't twist the coracoid, but I want that the larger part of the deep coracoid face to the glenoid neck. I use a small plate that improves the contact and also the tilt of the coracoid to improve the match between the glenoid bone loss and the deepest part of the coracoid. Because I use this plate, I need to have a guide that introduces key wire, and I do 2 holes with a drill that have the same distance of the 2 holes of the plate. So first I insert the key wire, then with a cannulated drill, I make 2 holes on the coracoid that have the same distance, as you can see here, of the 2 holes of the plate. I think that the use of the plate is very important also because keep this kind of surgery very easy, very reproducible. And I think it's not easy surgery, even in arthroscopic or open technique. This is the most important step, is the right shoulder. You can see the tendon here, you can see the muscular subscapularis. I want to make a split, usually in the middle or between the 2/3 superior and 1/3 inferior. Is the right shoulder, but keep in mind that here is the biceps. I want to make the split from lateral to medial. I want to save some tendon. I want to go through the muscles, and very important to have a very clean surgical field. You can see the superior part of the split. You can see the inferior part of the split. Very important is the underlying capsula. When I perform the split, immediately after that, I do a capsulotomy, and the direction of the capsulotomy is the same direction of the tenotomy. You can see here, right shoulder, we are working to the split. I don't detach the tendon, and I do a capsulotomy once again from lateral to medial. And I want enough space just to see the humeral head and to introduce the humeral hair retractor. So this retractor is very important on the glenoid. This is the humeral hair retractor, and I remove all the other retractors. At this point, this is the humeral head, this is the glenoid, this is the glenoid neck. If you have this kind of view, you are at a very, very good point, because you have only 2 debris. Most of the time you have 2 debris between 3 o'clock and 6 o'clock where the bone loss is. And for different reasons we can discuss, and we did some publication about this, to have the best integration of the coracoid, of the graft, you need to put the most distal part of the coracoid exactly where the bone loss is. Because the most distal part of the coracoid, I mean the part of the coracoid that is very close to the tendon, is rich of vessels. There is a very good blood supply. And if you put this part of the coracoid where the bone loss is, you have the best mechanotransduction. It means that you have a very good mechanical stimuli that is very important to improve the integration of the coracoid where the bone loss is. This is the perfect image. It's very normal that you have osteolysis in the most superior part, and it's very normal that you have a very integration in the most distal part, especially if the patient of this patient selection is of a huge glenoid bone loss. Keep in mind, the more bone loss you have on the glenoid, the best integration of the coracoid you have, because the mechanotransduction. It means that if you have a huge glenoid bone loss, you need the graft. And the nature, according to the Wolff law, gives the best integration. So don't be surprised if there is some osteolysis. And don't be surprised if you make a lateral jet technique. I don't mind in arthroscopic technique or open. the biology is always the same. We had in these patients 83% of osteolysis because the patients before the surgery did not have a huge glenoid bone loss. But even if we have a huge osteolysis, we had an excellent clinical results because the sling effect. So we can speak about these different effects after the talk. So keep in mind, when you give a look to the CT after 1 year and you want to see if there is a good osseointegration, remember that the more bone loss you have on the glenoid, the best integration you have. If you have a huge osteolysis, it does not mean that the Latarjet doesn't work. It means that you choose a patient with no huge glenoid bone loss, but with a minimal glenoid bone loss, where the Wolff law doesn't work because you don't need the bone if you have a minimal glenoid bone loss. But we are lucky because for some reason the effect of the Latarjet is not only the bone, but is the sling effect. I mean the common tendon and the most inferior part of the scapularis tendon. So this is the graph. You can see this is the key point, that the coracoid that is very close to the tendon is rich of vessels, is very rich of blood. So you have to face this part of the coracoid exactly where the glenoid bone loss is to have a good blood supply and to have the best biomechanics according to the Wolff law. And this is important, this video. You can give a look to this video. Look what happened if you don't have a huge glenoid bone loss or you have a huge glenoid bone loss. If you have a huge glenoid bone loss, you don't need the plate. You need 2 screws because it's flat. The problem is when for some reason you don't you do the Latarjet with a minimal glenoid bone loss. That is an issue because here the compression of the most medial part of the coracoid and glenoid is very complicated. That's the reason we have a plate with a middle wedge that, because the teeth of the coracoid improve the contact between the medial part of the coracoid and the glenoid neck. This is the final part, always the right shoulder. You can see the plate. We have a very special joystick that is cannulated. At this point, we have 2 holes on the coracoid, and we did 2 holes with the same technique on the glenoid. At this point, if you introduce a key wire into the joystick, it's very easy. You can see now, we make a compression of the plate on the coracoid. We introduce a key wire through the joystick, through the plate, through the coracoid, and we look for one of the 2 inferior holes that we did on the glenoid here, with the same technique that we did the hole on the coracoid. I insert the key wire here and another short key wire superiorly. And I use 2 cannulated screws. That is very easy. You can see the split, and with one hand I can place the coracoid exactly where the bone loss is, and I can introduce through this key wire exactly into the bone without any protrusion of the screw into the cartilage, and I can feel here with my finger if there is a 2 lateral coracoid. With a shaver I can do a debride, and I can keep flat the surface between the glenoid and the graft. Thank you very much.